Right. Well, good evening, everybody. Thanks for joining us for our Men's Health webinar. We're coming to a close for Men's Health Month here in June. We'll dive right in here. I'll introduce you to everybody online here with us tonight. We have our moderator, Dr. Allshaker. He specializes in enlarged prostate, or BPH, as well as prostate cancer management. I'm Brad Gill. I'm another one of the men's health urologists here at Cleveland Clinic. I also do quite a bit of prostate enlargement, as well as penile implants, helping men with incontinence or urinary leakage, and prostate cancer screening. We're also joined by Dr. Altman. He's one of our men's health specialists out on the east side and also does some general urology, but sees really anything and everything a man would need in the world of urology. Dr. Lundy is a new member to our team. He's been with us for quite a while, though. He finished up his training here just recently, and he's one of our infertility specialists. He also does a fair bit of erectile dysfunction, as well as specialized work with chronic testicular and scrotal pain. Without further ado, I'll kick it over to Dr. Allshaker here to say hello, and we'll go from there.
Great. Thanks, Brad. So yeah, I've been on staff from a personal level of each of these gentlemen give a little bit of background about themselves now for 27 years at the clinic. In some capacity, all three of these gentlemen were residents and trained with me. And yes, I've been in charge of male voiding dysfunction here at the clinic for the last for my career. And again, as Brad mentioned, does prostate cancer. I don't really see the other aspects of men's health that some of our other experts do. And again, I'll start then with Brad. Tell a little something about yourself, and then followed by Andy and Scott, and then we'll move forward.
Sure. So don't hold it against me. I grew up outside of Pittsburgh. I may be a Steelers fan, but I'm still a darn good urologist. So my major focus and interest really, similar to Dr. Allshaker's, is prostate enlargement and voiding dysfunction. I also help men with leakage problems. So not just trouble emptying, but also emptying too much, too often, and too well. Surgical management of erectile dysfunction or penile implants is another area of interest. It's a nice option for guys who haven't responded well to medications or who may need other treatments. Beyond that, I did all my training here at Cleveland Clinic. Been around for quite a while, and it was really a pleasure to be able to join the team after residency to come on and help build our men's health program. So thanks, Dr. Allshaker. I'll kick it back to you.
Great. Andy?
I'm Andy Altman, and it's been my pleasure to work with everyone on the panel here today. I've been in practice since 2001. I actually am the odd man out because I trained across the street over at University Hospitals. I used to be the head of urology at Kaiser Permanente until 2015 when they closed up shop here in Cleveland, and I've been working at the Cleveland Clinic ever since. I'm a general urologist with an emphasis on men's health. I do a lot of enlarged prostate surgery with a special interest in minimally invasive procedures. I do a lot of urolift, and I also have an interest in hypogonadism or low testosterone. And I'm a general urologist, so I see a lot of stones, evaluate men for things like blood in the urine and various general urological complaints. And I'm a Buffalo Bills fan, big time. We're going to the Super Bowl this year.
Okay. Dr. Lundy?
Good evening, everyone. My name is Scott Lundy. I am the newest member of this panel on staff here at Cleveland Clinic. I hail from the Pacific Northwest, came to Cleveland about 7 years ago and completed my training here, and then did an extra year in special training fellowship in male infertility and erectile dysfunction, penile prosthetic placement. We also do a lot of work with testicular pain and scrotal pain and operations to treat that type of pain, as well as vasectomy. So I'm happy to help, and I'm happy to be involved, and looking forward to having everyone's questions.
Great. Thanks, everybody. Daryl, next slide, please. Okay, so just a couple of brief slides to stir some thought processes, and then we're going to have you. We have a list of questions which were already submitted, and then some of that we've done on our own that I will ask. But we want to make sure that the people on the webinar get their questions answered as well. And so when the time comes in a few slides, we'll have you submit questions through the chat, and then we will read each of the questions and then have the appropriate expert comment or experts comment to try to get your questions answered. So why men over 40 should see a urologist? Well, a men's health expert can help guide you on what to expect, lifestyle changes, when to simply observe and when to treat a problem. And men's health conditions often share the same signs and symptoms. So there may be a simple explanation, an easy fix, that there's a chance that you could need treatment before something gets worse. Next slide. So when to see your doctor? Some things are fairly simple. If you have blood in your urine and you see the blood in your urine, you probably ought to see a urologist. The semen, most blood in semen is benign. It may deal with infection. It may be very self-limited. But again, if you have concern, you should see your doctor. Urinary problems, including pain with urination, frequency, needing to go all the time, hesitancy, which is getting started or a weak flow. Again, if it's bothering you and it's a quality of life issue, it's time to see your doctor. New or worsening erectile dysfunction, again, that's a time that you can consider. Painful ejaculations, pain in your testis. If you feel a lump in your testis, absolutely, you ought to see your doctor. Penile curvature, there's more and more talk and discussion regarding seeing your urologist for that. They are directly marketing the consumer, as many people on the webinar will know, and there are some new treatment options which were not available 5 and 10 years ago. Again, from an infertility standpoint and inability to conceive a child for over a year, that may be something, and I'm sure we'll have a question on that Dr. Lundy will be able to address. And the desire to prevent future children as well, that can be addressed later, and going over the options of vasectomy as well as other urologic issues regarding that. Next slide. So again, just a quick background regarding that. So please submit your questions in the chat box. We'll get to as many as possible as we go. And if we don't see any in the chat box, then as the moderator, I'm going to ask each of our individuals some of the questions that we think that many individuals on this webinar may be interested in knowing the answers to. So, gentlemen, any further comments before we're waiting for the chat box?
I think it was a pretty good overview. To recap some of the stuff we've done years past in men's health. One thing we know is guys are somewhat reluctant to go in and get things checked out, right? We're the tough guys. Something's going on. We'll wait it out. We'll tough it out. Maybe it'll get better. Maybe it'll go away. A lot of what we see in urology and a lot of what we do in men's health deals with prevention and screening for problems. And, prostate cancer is one of those things. Prostate cancer won't cause symptoms and it won't cause problems until it's incurable, until it's at a point where you can't do anything to get rid of it. It's really too late. So it's important once you hit a certain age, 40, 45, somewhere in that range, you start to see your doc every year. And that could be your family doc, that could be us urologists, but we want to be part of that conversation and help you screen so that you can stay ahead of things. So that if you do catch a prostate cancer and you catch it on screening, it's treatable and it's curable. So, men's health and urology go hand in hand. And a lot of what we do is try and prevent problems before they really become too big to handle.
Okay, still waiting for any questions through the chat box. Let me,
The questions are in the question and answer section on the lower right. If you expand that, there's questions there right now.
where is that?
Yeah, where's that?
It's at the lower right-hand corner of your,
Q&A.
yes, just expand that box, click the down arrow there.
Oh, I got you. Yeah. So there's two. Hi, I'm Mr. Schmidt. Pleasure that you're on the website. I won't get into how you and I know each other, but it's been many, many, many years, and thank you for being on. We have another question. Has there ever been a study to identify a potential link between vasectomy and Peyronie's?
Not that I'm aware of.
I will leave that for the other three individuals to comment on. Let's start with Dr. Altman.
Yeah, I'm not aware of any particular study, but one comment that I'd like to make about that is, and it seems, after having been in practice for a while now, that every 5 to 10 years, another study comes out linking vasectomy to something, be it Alzheimer's disease or prostate cancer. Just by looking at historical numbers and doing the number crunching and so forth, nothing has ever been proven. And quite honestly, there's really no mechanistic correlation that I can think of between vasectomy and anything as far as prostate cancer or Peyronie's disease is concerned. So there may be a study. I don't know of it, and I would be very, very skeptical if there were such a correlation.
So just to provide a little background here for those of you who aren't familiar with Peyronie's disease, this is a scarring condition that occurs of the erectile tissues of the penis that we think happens from small little repetitive micro traumas. And as that tissue heals, the scar tissue tightens just like it would on your skin or any other part of your body. And that tightening causes a curvature or a narrowing in some cases. But a vasectomy is a procedure that we do through the scrotal wall, which is far away from the penis and only interrupts the small tube that carries sperm, not the rest of the ejaculate. And so, as Dr. Altman said, there isn't really a good basis for that, other than to say that both of these conditions or procedures are very common. And sometimes just because two things happen at once doesn't mean that one has caused the other.
Dr.
I
Gell?
agree with you, Scott. One of the things I think about with a lot of these studies, they get press. They're exciting, right? It's like, oh, guys that have vasectomies, they have this happen, they have this happen. In reality, what I think they really show is that guys that have had a vasectomy may be more likely to have followed up with a urologist for other things, right? They're already plugged in, they're already engaged, they're following their PSA, they've had that cancer treatment or cancer screening discussion. So I think a lot of what we see are really statistical artifact, to echo really what you and Andy said there. Vasectomy is safe, it's very effective, it's a great way to achieve, permanent birth control. And there's really no, proven links or downsides.
Yeah, the only thing I can think of that I remember from many, many years ago was that there is a potential complication long term called a sperm granuloma, which is like an epididymal cyst. It's a small little bump you may feel in the scrotum after a vasectomy, and this small little cyst is filled with sperm, can be painful. It's usually only about the size of a pea, but that's again the only thing that I can relate. I've never heard of anything, again, not the area of what I do, but not really the area that I can remember regarding that. We're having some, I don't know, Brad, how you're getting these so fast. But one question, any improvements in male incontinence as a result of prostate removal treatment?
Sure, I guess I'll lead that one. That's a great question. So, the prostate sits between the bladder and the urethral sphincter muscle, the muscle that holds your urine in. And with treatments for cancer, could be prostate cancer, bladder cancer, could be radiation, could be surgery. It can even be procedures done to help reduce prostate size and improve urination in a man. Those all carry a risk of leakage problems. Some men may even have leakage without any of those things being done. There's a number of things that can be done to help. You can have surgery where you install a hammock or a sling, and it tightens up the channel to prevent the urine from leaking. It's an in and out same day procedure. Some men who have more severe leakage might want to have an artificial sphincter device put in. And that's like a blood pressure cuff that would go on your arm. It's a little valve that goes around the urethra that opens and closes. And it replaces your natural sphincter function. You get a little pump in your scrotum to operate it. And that too is an in and out same day surgery. Men who have leakage for other reasons, maybe irritable bladder, things like that, you can be treated with medication. There's also pacemakers or nerve stimulators for the bladder. There's really a number of things that can be done to help a man reduce leakage, depending on the specific situation.
Great. I'll actually take the next question because it refers to my research. The question is, please discuss prostate artery embolization. So at the clinic, from a urology side, I am the clinical investigator with PAE, or prostate artery embolization. We do this in conjunction with our interventional radiologist, who is the individual who performs the procedure. For a while, prostate artery embolization was being done overseas, mostly in Argentina, Portugal, some in Spain. And basically what it is you put small spheres or coils into the arteries that feed the prostate, and you essentially try to shrink down the size of the prostate by starving it, by decreasing the blood flow to the prostate. For most of the publications that are currently in print, it is for small prostates. We are not looking at the Cleveland Clinic for small prostates. We have plenty of great things to treat small prostates, and we can get into some of those treatments because some of my colleagues do these as well. But some may be Urolift, some may be Resume. We're going to be beginning to do one called iTind. Those are office-based therapies. There's still TERPs and green light lasers and holmium enucleations and button electrovaporizations and things for moderate sized prostates. We're only looking at prostate artery embolization for large prostates, 150 grams in size or greater. And this is actually looking at it in comparison then to what we call robotic simple prostatectomies and holmium enucleations of the prostate. But that's the basis for prostate artery embolization here at the Cleveland Clinic.
Hey, Jim, who is not a candidate for prostate artery embolization?
So we know that, well, at our place, less than 150 grams, you're not going to get it because we're doing it from an in-house clinical trial standpoint. But be aware that if on one of the studies that we do before we do any of these procedures is what's called a urodynamics study. And if a man is not able to generate a good, strong bladder contraction, prostate artery embolization may not be your best option, because again, you probably need to better debulk some of that prostatic tissue, either with a holmium enucleation or with a robotic simple prostatectomy. So yes, we still offer it by letting people know that, please understand, you may try this and it may not be successful. But those are really the ones that concern me, are people who, again, have very poor or hypotonic bladder contractions. Let's see, next, again, I'll go on to one of our prepared questions that was sent in before.
Dr. Ilshaker, I think there's a question at the top of the Q&A that we might have skipped over accidentally.
Oh, hang on. I can go down the screen. This is what is the, there you go. What is the, yeah, I found more here. What is the success rate to achieve regular penetrative sex after a penile implant?
Very high. I'll turf this one to Scott.
So a penile implant is a surgery that's been around for about 50 years now. It was actually our first treatment for erectile dysfunction, and we still use it frequently. And many of us on this call do this operation on a regular basis. And the implant is a device that we surgically place inside of your body. The most common type has 3 pieces, and it's an inflatable device, which means that the 2 erectile cylinders on the penis are replaced with saline-filled cylinders, and the fluid can be moved back and forth between a reservoir that sits inside your belly where you don't feel it, via a pump that sits in the scrotum. Much like the old Nike Air shoes, you pump this pump and it brings the erection up on command. This erection will stay as long as you want, even after you orgasm, until you tell the pump to release the fluid back into the abdominal reservoir, and the penis becomes flaccid again. The device takes about an hour and a half to put in. Most of the time you go home the same day and you recover for up to 6 weeks, and then you can use the device. And the average device lasts a little over 20 years in the modern era. And so the question about success rates is a little bit tricky, because the success rate to have a strong erection with a penile implant is essentially 100%, as Dr. Gill hinted at. It's a strong, firm erection that is absolutely adequate for penetration. The better question is satisfaction, and we know now that the satisfaction for this operation is above 90%, both for the men who have the implant, but also for their partners. And so for many men, this is a great option. And if they've already failed more straightforward treatments like pills or potentially injections, then a penile implant is something to discuss with your providers.
Great. Thank you, Scott. Next question, I think, is going to be for Brad Gill. What is scarring during Holap, and what are the implications? Brad?
So that's a great question. So Holap is a procedure where a scope is used up through the penis, through the urethra, to peel the prostate out and open it up so a man can urinate better. It's a procedure done to unblock flow. Think of a watermelon. You're peeling the pink fruit out of the inside of a watermelon, but you're leaving the white rind and the green skin behind. So anytime you do any kind of a scope procedure, anything that goes up through the penis, through the urethra, whether it be a surgery or looking with a camera or having even a catheter put in, there's always a risk of scar tissue formation if something gets stretched or torn a little bit. And when scar forms in the urinary channel, because it's a tube, it causes it to narrow down and close up. So depending on where scar forms, with a Holap, it could be where the bladder and the prostate meet, far inside. It could be in the middle of the prostate, or it could be anywhere in the urethra, the tube that goes out through the penis. Depending on where that scar is, you treat it differently. It may require a stretching procedure. It might require a procedure where it's cut open. Or if the scar is pretty substantial, it may require a surgery where you go in and you actually take out part of the tube and rebuild it. It's a case-by-case, condition that's treated, and it usually requires a scope procedure or X-rays to further diagnose it and find out where that scar may be and how to best treat it.
Gotcha. Next question comes from a gentleman. I am a 58-year-old male, married 36 years, recently diagnosed with Gleason 6 prostate cancer with a growth on the anterior side of the prostate. My urologist expects to find a higher Gleason number. I'm not in favor of prostate removal. A close colleague shared his perspective of significant sexual satisfaction reduction after prostate removal. I'm interested in your opinions of the latest ablation options that I should consider. One of the things, sir, and again, that would be helpful for us is if we had a better knowledge of your PSA, if your PSA is 40 versus if your PSA is 4, I think we'd be able to give you a little bit better answer to your question if you can potentially send that in for us. But
looks like it's about 6.
Well, yeah, but I mean, we could say it's for 6, but I think he's got a specific question for us that, anyway, let's say it's 6 until we maybe get his result or his sent in to us. For those gentlemen that are doing focal ablations, go ahead and give your start.
Well, I would just like to, this is sort of a nice segue to bring up the option of active surveillance. I think when it comes to prostate cancer, the disease is a spectrum. So Gleason 6, as you mentioned in your question, is what we also call grade group 1. We often consider it low risk and appropriate for active surveillance. Active surveillance does not mean that we're blowing off your prostate cancer. What it actually means is that we're watching it very closely and giving it an opportunity to declare itself as potentially clinically significant or a potential threat to your health or your life. So in that time, watching it, you wouldn't need to worry about the potential urinary and sexual side effects from prostate removal. Taking it a step further, of course, the ultimate ablative therapy is radiation. Brachytherapy actually has an outstanding side effect profile with respect to urinary and sexual side effects when you compare it to external beam radiation and surgery. So that's something to think about. And of course, focal ablation as well. So as Jim was saying, we don't know what your PSA is. We need a little more information. But the first thing I think of when I hear that someone has Gleason 6 prostate cancer is, as long as it's a low volume cancer, active surveillance is probably the way to approach it initially, rather than moving forward with treatment, radical treatment like surgery.
So those of you who are on the webinar, we did get our answers with 5 different PSAs ranging from 5.69 to 6.80. Anybody else, before I give some comments regarding this gentleman's question?
Yeah, I just quickly want to say that your comment about the anterior side is potentially important, and the concept of localizing this and using things like an MRI to help identify whether the lesion was adequately sampled on your biopsy is important. One of the things that a number of our staff member here do are things like transperineal biopsies, which allow us to access the anterior part of the prostate. And then based upon that information, if indeed the cancer is higher than a Gleason 6, then we can offer a number of different focal therapies like HIFU or partial prostatectomy. But these are all relatively new treatments. And so it's a decision that's made on a case-by-case basis with your surgeon. And so, we can talk generally about the options, but there's a lot of nuances here, I'd say.
I would just like to reiterate a little bit about what Andy said about active surveillance, but I wanted to add one more twist. Over the recent years, there have been tests known as genomics tests, which now exist. I don't think we have discussed that yet, and I have no idea whether your urologist, sir, discussed genomic testing with you. We know that there are certain genes associated with prostate cancer that may be more associated with metastatic disease or death from prostate cancer. And we now have the ability to check for those genes. And it's not just whether you have gene 1, 2, 3, or 4, but it's also how many copies of the gene you actually have as well. And each of these 3 tests, one is called Oncotype, one is called Decipher, one is called Prolaris, have different proprietary formulas that they use, but they all do essentially the same thing. And they better let you know and give you information of whether or not you may be a good candidate for active surveillance. So it's one of the things as well I would ask your urologist for, whether genomic testing was done, and if not, for a Gleason 6 PSA 6 cancer, you'd be a very good individual to have one of those Oncotype or one of those genomic tests. Again, the transperineal biopsy comment was responded to, and again, could be a good course. I have no issues with that at all. We have one question that at 85-year-old, PSA went from 124 to 3. How can such a drop happen with Xtandi treatment? Anybody like to comment on that?
Well, these are new drugs. They're outstanding. I think we're sort of veering more into the realm of advanced oncology, which I think we're all happy to discuss. But that's probably a better question to direct toward an oncologist.
Yeah, there are many individuals, urologists, who do prescribe some of these new chemotherapeutic agents. At our institution, though, at the Cleveland Clinic, that is all handled by medical oncology. That's not handled by us in urology. And so, again, I agree, since we don't really prescribe that, that's really best served by the medical oncologist, not by us. But we do thank you for the question.
That may be a nice segue into testosterone, though, which is a big topic of conversation. So the long and the short of that question about the Xtandi is the drug turns off testosterone to prostate cancer. So because of that, the prostate cancer shrinks down, slows down, decreases in size, and it produces less PSA. But it brings up the big question of what is testosterone? What does it do? From a hormone standpoint, how does it impact us, as men? I'll punt that one over towards Scott and Andy. Any thoughts on that?
So in general, testosterone is a very important hormone for male function, and the levels change dramatically throughout the day and throughout your life. But we do now think that as men get older, the testosterone levels can drop, and as certain medical conditions occur, like diabetes or obesity, the testosterone levels can drop further. And if they drop too low, then some men can develop symptoms like low sex drive or low overall energy or erectile dysfunction. And so it's important to understand that some of these symptoms can be treated if we were to diagnose low testosterone and treat it appropriately. Now, it's important to recognize that testosterone treatment has to be done in an appropriate manner and can't be used for untoward reasons or without the approval and monitoring of your physician. And so that is something to keep in mind and something to follow closely with when you see a urologist or another provider who prescribes these medications. And I'll turn it over to Dr. Altman if you'd like to add anything to that or talk about treatment as well.
Yeah, no, absolutely. I think just to sort of dovetail on that, I think it's important to understand that low testosterone itself it's not a disease. It is not a condition that has to be treated. However, it can be a cause of low energy, fatigue, difficulty having success in the gym. Diminished libido is a very common side effect of low testosterone. So by doing testosterone replacement therapy, we can have a positive impact on a number of those symptoms. However, even with testosterone replacement therapy, you may not see an improvement in the symptoms because the symptoms are very sort of general. As far as obesity, being diabetic, and so forth, in my practice, I think the men that benefit the most from it are your 50, 60 something year old gentleman, overweight, type 2 diabetes, sort of with a beer belly, who is having trouble controlling his diabetes. His A1C, which is a blood test we use to monitor diabetes, is the A1C is difficult to control. By diagnosing low testosterone and then offering options for testosterone replacement to bring the level not into a high level, but just the upper range of normal. As I mentioned, we can improve symptoms, but we can actually also help with diabetes control and getting those sugars under control and increasing the ability for these men to have some success in the gym and achieve some weight loss. So there are a lot of things that we can impact with testosterone replacement therapy. I don't consider it a treatment for erectile dysfunction. In my experience, testosterone replacement is very helpful for libido, but really doesn't have that much of an impact on erections. It probably does, but not that much. And then the other thing that Dr. Lundy was talking about, it's very important for testosterone replacement to be done by a men's health physician who's experienced in the side effects, all the available treatment options, and will monitor men closely. There are a number of outfits around town who actually charge membership to any man who wants to have testosterone therapy. They'll start you on therapy, and they'll keep you rolling on therapy until you can't pay your membership anymore. And there's really very little monitoring. So I think it's you don't want to just get on the cycle of testosterone replacement unless you've been appropriately evaluated and you've been presented with all the available options, and you're fully aware of what the potential downside could be.
Next question, I'm going to paraphrase it, but I'm going to address this initially to Dr. Gill, and it deals with Peyronie's treatment with removing the scar, putting a patch in place, and B, will it affect testosterone levels? The answer from all of us to question number 2 is treating Peyronie's is not going to affect your testosterone, whether it's your free testosterone or your total testosterone. It's not going to have any effect at all. I just wanted to change the question around a little bit to Dr. Gill, which is can you talk about the 3 types of treatment for Peyronie's? He mentioned 1, the removal and the patch. but can you also discuss plication? And can you also discuss Xiaflex treatments?
Absolutely. So, as mentioned earlier, Peyronie's, it's curvature of the penis. I describe it to patients as the arthritis of the penis. It's basically a wear and tear condition, we think. We're not entirely sure how it happens. So you get scar formation in there that occurs, and what happens is when scar matures, it contracts, and it shrinks, and the shorter side of the penis pulls the longer side over. So that's really what's happening. And somewhere in there, there's a little wad of scar that's causing that to occur. So the treatment mentioned in the question is excision and grafting, cutting the scar out and putting a patch on. We generally reserve that for very severe cases of Peyronie's disease. And the reason is it's a very complex procedure. There's a high risk related to having it done. It can impact sensation in the penis. It can also cause erectile dysfunction with healing. It carries a very high rate of that. Maybe 1 in 3 men who have that done can experience that. So that's a very specialized procedure that we really reserve for complex or very severe cases. More often, though, men that come in with Peyronie's can be treated with non-invasive or minimally invasive treatments. The non-invasive ones are penile modeling or stretching. Think yoga of the penis or physical therapy of the penis, right? So what you're doing is trying to work that scar tissue, stretch it out and elongate it so that length discrepancy goes away. Penile traction therapy, it's a device you put on. You have to walk around your house with no pants on for 15 or 30 minutes each day. But what that does is it stretches it out and it holds that scar to hopefully reduce the curvature. Xiaflex treatment that Dr. Allshaker mentioned, it's an enzyme that's injected into the scar tissue, and it helps dissolve it and soften it. It doesn't do much on its own, so you still have to do the bending and stretching exercises or that penile traction therapy. It just helps those treatments potentially work a little bit better. It's very expensive and sometimes a challenge to get covered by insurance, but where there's a will, there's usually a way. Beyond that, the plication surgery, very elegant, very quick and slick. If you have a curved penis, you go to the opposite side of the curve, you put a couple stitches in, tighten it up, and you straighten it out. So you basically take the longer side and just straighten it to match the shorter side. One other treatment, penile implants, we mentioned that a while ago. That's a very nice way to address a situation where a man not only has Peyronie's and curvature, but also may have erectile dysfunction that's not responding very well to other treatments. So there's really a large spectrum of treatments out there for Peyronie's disease, and they really depend on the individual situation. So, it's an informed discussion with your doctor, an examination. Believe it or not, it's actually helpful to come to those appointments with a picture. So that's something we often encourage. If you can get a picture of things when they're curved and bring it on your phone, that's helpful for us to see. Some folks out there will give you medicine in the office during the visit to produce an erection so that they can assess the curvature there. But a lot of us just simply rely on, bringing a photo and really a good examination.
Can I just ask a question about that? So I do Xiaflex, and I haven't been overly impressed with it. I've gotten into the habit of telling patients that we can probably get them a little straighter, and I do think that that's true. But I'm careful to lower the bar with patients and make sure that they understand that we're not really going to be able to make you perfectly straight with the Xiaflex injection. So if they're looking for a perfectly straight penis, application is probably the way to go. If they're just looking to have penetrative intercourse without pain to themselves or their partners, then I think Xiaflex is reasonable. So what's been your experience with that?
So I just quickly want to hop on and thank Dr. Gill and Dr. Altman for that great summary. Peyronie's is a disease that is not associated with cancer or other problems of the penis. It is a disease, not even a disease, it is a condition that you do not have to treat unless it's causing problems. So if you have a bend in your penis and you're able to have intercourse and it's not painful, then there's no reason that you need to undergo treatment. It's likely going to stabilize and stay the same, and you can live a happy, healthy life and have a great sex life with that slightly curved penis. And furthermore, many men have a curvature in their penis from birth, a congenital curvature, which is quite different than Peyronie's and is treated in different ways and is not a candidate for something like Xiaflex. So it's important to recognize that this is a lifestyle issue and an issue to maximize your quality of life as opposed to a disease or problem that absolutely needs treatment. And I would agree, Dr. Altman. I think Xiaflex offers a subtle improvement, 10 to 20% improvement in the curvature, as opposed to a cure for the problem. And as long as you set your expectations reasonably within those confines, then doing that and the traction device that we talked about is reasonable. But the other options are for more involved curvatures.
Okay. Next question is regarding postoperative issues post brachytherapy. And are there treatments available for BPH and ED after a brachytherapy procedure? I'm going to direct this initially to Dr. Altman. Dr. Altman and I have been doing brachytherapy cases at the clinic for a long time. Even when Dr. Altman was at Kaiser, he was still working with our team doing brachytherapy cases. For those of you who may not know, the Cleveland Clinic is the largest brachytherapy program in the United States. We've done over 7,000 cases. I have 4 cases, for example, tomorrow. But I'm going to start with Dr. Altman. What do you offer people from abilizing dysfunction standpoint, or maybe in urinary retention post brachytherapy?
Yeah, so brachytherapy, these are the radioactive seeds that are implanted for prostate cancer. It's a form of treatment which is equally effective when you compare it to surgery or external beam radiation. The nice thing about brachytherapy is it can be done as an outpatient. Dr. Allshaker is doing 4 cases tomorrow. Those 4 gentlemen will be out of the hospital and back home 2 hours after the procedure is completed. The radioactive seeds slowly release their radiation actually over an 8-month period. So we call it a low dose rate. And as that radiation is accumulated within the prostate, there is some swelling and irritation. So most men do experience some urinary urgency and frequency. And 4 to 6% of men can actually experience obstruction or go into urinary retention and need a catheter. Right at the outset, when a seed implant is done, I like to start everyone on a maximum dose of an alpha blocker, a drug we call Flomax, in anticipation of those symptoms. We also teach our men how to do in and out self-cath on the day of the seed implant if they find themselves in that 4 to 6% group of men who actually need to do self-cath, because it's usually temporary and it's a very easy thing to manage. And ideally, we'd like to keep these men out of the emergency room. So we teach them and we give them a few catheters on the day of. Unfortunately, there's a very, very small group of men who find themselves in retention, and the retention lasts beyond the initial couple of months. And I just want to emphasize that this is a very, very small group of men. The issue with them is we don't want to do, so to speak, anything in terms of surgery until the seeds are completely inert. So we usually wait for a year. And the most common treatment we do is what's called a channel TURP, where we just gently scoop the prostate out with a tool we call a resectoscope. TURP stands for transurethral resection of the prostate. A prostate that's radiated doesn't heal that well, tends to slough and scar, so we don't want to be too aggressive about it. Now, I have, and Jim, I'll direct this to you, I have 2 patients that I've actually implanted with Urolift who've had brachytherapy, the thought being that we're not cutting into the tissue and we're avoiding the scarring and the potential of prolonged healing and sloughing. I can't say that I've actually had great success with that. So beyond alpha blockers, catheters, and a rare channel TURP, there's really not much more to do. And I'll direct it to you, Jim.
Yeah, so in fact, Andy, you're going to be on the publication, et cetera, with Dr. Gill, myself, and we have one of our residents who's looking this up. Over the years, we've done Urolift. The Urolift at times is successful. It is not as successful as if it was what I call virgin tissue, which is not radiated tissue.
Yeah, because it's
Because
thick. It doesn't
post radiation, the tissue is not as pliable, and you don't get the same opening as you do. But it does work in some men. For years, we tried doing green light lasers, other laser therapies for these men, but the problems with the lasers were the light energy would come off the fiber, would come right back and damage the fiber tip, and you'd be going after, it'd be too expensive going after tip after tip after tip. We, again, TURPs are the most common thing that are still done. However, we are going to be we have not begun this trial yet, but there is a new device out there called an iTind. Okay, this is a device now that Olympus has brought to market. It was originally, the original trials were done in Israel. Olympus bought the rights. We are going to be heading the United States controlled trials with this and doing our own trial post brachytherapy or post radiation therapy with this. This is a device that is cystoscopically placed inside the prostatic urethra, and it's left there for 5 days, potentially 7 days in radiated tissue. But what this device does, the best way I can describe it is, if anybody knows what a Mercedes-Benz type of logo is, whether there's a line that goes up at 12 o'clock, 4 o'clock, and 8 o'clock. And what this does over that 5 to 7 day period is it slowly makes cuts in the prostate tissue, springing the prostate open. And then the device is removed after 7 days, 5 to 7 days. Whether or not we're going to have long-term results post-radiation, that's why we're conducting the trial. There is no real data that's out there that's longer than 1 year, but it's a new device that we may be, it may be of some benefit in this particular situation. There was one question: can testosterone gel cause prostate cancer? I'll let our hormonal experts just give a very short, brief answer to this, and then I have one more question that I'd like to ask.
So testosterone in general does not cause prostate cancer. This has been fairly well shown at this point. There is a hypothesis that it can increase the growth of some types of prostate cancer, but we're now understanding that this relationship is much more complex than we originally thought. And in fact, many men with prostate cancer on active surveillance can be safely treated with testosterone therapy. Men who have prostate cancer who have been treated with surgery or brachytherapy can have testosterone therapy. And even if we take the most complex cases where patients have metastatic advanced prostate cancer, there is now data to suggest that giving them a blockade of testosterone and then giving them testosterone can improve their outcomes over just blocking testosterone in general. So we don't think it causes it. We do think that there are patients who can have it safely in the setting of prostate cancer and some who may benefit, but it's a subtle and an ongoing discussion that needs to be had with your physician and with clearer data coming in the next few years.
I agree.
Great. Then in the last couple of minutes that we have, we had a question that came in on what are your thoughts on shockwave therapy? And I'm thinking that shockwave therapy for erectile dysfunction, only because it's new, it's being marketed, and but give our individual your experiences, plus good and bad with shockwave therapy.
I can give a quick overview. So shockwave therapy is the idea that delivery of energy to the penis through one of two different kinds of waves of energy can improve erectile dysfunction. It has also been studied for Peyronie's disease, but we now know that there's no role for shockwave therapy in improving the curve of Peyronie's disease. So it's not used for that and shouldn't be used for that. When we talk about shockwave therapy, there's radial waves and there's focused waves. And it's important when you consider this as a treatment option to explore which type of machine your provider is using, because there is now excellent evidence to suggest that radial shock waves have no benefit whatsoever in treating erectile dysfunction, despite the fact that many facilities will charge large fees for its use. There is a role for focused shockwave therapy, and we do offer this as a treatment at Cleveland Clinic. The important facts to know are that it's a treatment that takes 6 weeks, once per week, and it offers a modest benefit. So the analogy I use is if you're in a car and you want to go from 0 to 100, shockwaves won't do that. Similarly, shockwaves may not be the best treatment for men after a prostatectomy. But if you want to have just a little bit of an improvement, you're going 50 and you want to go 70, or you're going 50 or 60 with pills and you want to go 60 without pills, then shockwave may be a reasonable option, and that is something we can discuss. The downsides are that it's a procedure that's not currently covered by insurance. While it's safe, it does have this cost associated with it. And so we want you to understand that it's a modest benefit should you choose to proceed with it.
Great. It is 5:59, so we're in our last minute. I would just like to take the time to discuss two real quick things. Number one, you can see on our screen, and some of us are going to be participating in this event as well. But on Wednesday, July 20th, same bat time and same bat channel. For those of you who are older people, I think some of our guys may not know what that even means, Scott Lundy. That from 5 to 6 on Wednesday, July 20th, we're going to be having our question and answer period for BPH and talks about the different therapies for BPH. And again, these are some of this is the next event we have, but there's going to be many more on different health topics again as well coming up. And again, to thank our media relations people who do a fantastic job with us. The other is that for those of you who may be interested in making an appointment with one of our health experts in men's health, you want to jot this number down, and that you're going to call 216-444-5600. To repeat that, that's 216-444-5600, and that's to make an appointment with one of our men's health experts, and to go from there. Any last words from our three other experts here on the webinar?
I'll throw one quick one out. That last question that squeaked in before the deadline: is there a recommended diet or lifestyle change to improve testosterone levels? The long and the short answer is no, but the summary answer is good, clean, healthy living. So you don't want to eat too much junk. You do want to exercise regularly. In general, the recommendations for cardiovascular disease, really any benefit from exercise, is 2.5 hours a week of cardiovascular, aerobic, make you sweat, breathe heavy kind of exercise. The best way to think about that is 30 minutes, 5 days a week, or however you want to break that 2.5 hours up. But a good balanced diet, good, clean, healthy living, and regular exercise are the best way to naturally keep up your testosterone levels, your energy levels, and also evidence has shown that they'll help improve the quality of your erections. So that's my parting thought. It was a pleasure to participate. I'll pass the mic.
Thank you for leading us, Dr. Allshaker.